Hello, I am your host, Jack Braha, and welcome to the Medcast Plus show. On the show, we feature local healthcare providers and physicians to educate us on various medical conditions and provide us with some very helpful health tips. Today, we welcome Dr. David Silver, Chief of Urology and the Director of the new Prostate Center at Maimonides Medical Center here in Brooklyn. We will discuss how to detect prostate cancer and the latest treatments available to patients. Welcome to the show, Dr. Silver.
Thank you. Thanks for having me, Jack.
Good to have you. So tell us a little bit about yourself, where you're from, and how'd you end up here in Brooklyn?
You really want the whole story here.
The whole story. We've got a couple hours.
So I grew up in Colorado. I came to New York for medical school. My parents were New York expatriates, and they couldn't get away from New York City fast enough. And I stayed. I went to medical school at Albert Einstein, came to Brooklyn shortly thereafter, and did my internship and then residency in urology and in surgery at Maimonides. And I was away for 2 years as a fellow at Memorial Sloan Kettering Cancer Center in only urologic oncology. And I've been back ever since.
So tell us a little bit about that. After you did your surgical training in urology, you went on to Memorial Sloan Kettering, one of the top cancer centers available to us in the country even, and you did your training there. Tell us what is entailed in becoming a urologic oncologist.
Well, it's either a 2 or a 3 year fellowship. At the time that I was doing it, there was a year of research followed by a year of clinical. It wasn't quite the same service that it is now, and the relationship with the mentors was really very, very close. And it was an excellent experience. We send residents there now as part of our residency training program, and there's value even for a couple of months for someone who's not going into oncology to live, eat, breathe, and sleep the oncology world.
So tell us a little bit about the new center, which we mentioned at the top of the show, the Prostate Center at Maimonides Medical Center. Tell us what this means to the patients and the viewers out there today who are concerned about prostate cancer, prostate disease. What does this center do for them?
So the Prostate Center is the culmination of many, many years of work. This idea started many years ago. And there were a number of individuals who were really siloed within their different specialties. A radiation oncologist doing radiation oncology in the basement, a urologist a few blocks away doing surgery in the hospital, a medical oncologist giving chemotherapy in an infusion center. And it really coalesced around a conference where we realized that all of the stakeholders, including the pathologists, including the radiologists, should get together and discuss all the cases and interact in a multidisciplinary approach so that the patients would have the benefit of multiple opinions for their situation. So we started doing the conference probably 8 or 9 years ago, and it got a lot of buy-in. It got buy-in from the residents. It got buy-in from the fellows. It got buy-in from all the physicians, from the cancer center leadership. And then the next step, obviously, was to wrap this up as a program to formalize our offerings and ensure that every patient has the benefit of having a multidisciplinary approach, which is really the way cancer care is headed in general.
Yeah, I think the patient's feeling of the one-stop shop, meaning that under one roof, they can see all the different specialists, that there's a team approach to this. And that's very important, what you mentioned, is that teamwork approach to healthcare. So it sounds like the Prostate Center has coordinated all these specialists together. So when someone is concerned about or receives a diagnosis of prostate cancer here in Brooklyn and they want to come to the Prostate Cancer Center, what is the pathway? How are they meeting all the team members? What should they expect when they come to meet with you guys?
So there's many different points of entry into the Prostate Center. It can be through a direct referral to their medical oncologist. It could be through a direct referral from their internist, or even from someone they know who's had prostate cancer and has been treated before at the center or elsewhere. There is a point of contact. We have a prostate center coordinator, Jeff Wynn, whose job it is to field the calls and speak to patients and make a decision based on what the situation is about where they should start first. No matter where you start within the center, you end up pretty much in the same place. You end up having gotten imaging studies, having review of prior studies, prior biopsy results, of speaking with some of the physicians who are involved, and then at the end of that process is a presentation, which patients sometimes attend actually, about their case and about where we think we're as a group should be headed next. With this particular situation, whether we're ready for treatment, whether it needs more evaluation, and we try to reach a consensus, although I have to say it's not always a consensus, and that's good, to have multiple different opinions for a particular situation is quite good. It gives people options.
Yeah, I think patients don't always realize that when we find tumors, like in our practice of gastroenterology, when we find a tumor in the colon, we present it before the surgeon, the oncologist, the radiation oncologist, at something we call tumor board. And I'm assuming that's the conference type that you have there where the cases are presented. And yeah, doctors will go and argue that, hey, this might be a better treatment for the patient as opposed to one treatment. And at the end of the meeting, we come up with what the group of doctors feel is the best step forward for the patient.
But you probably don't always get the same answer.
I think every patient is individualized, and I think that's what we want to provide these days in medicine is really individualized medicine, in that some patients may be best for surgery, some patients may be best for alternatives to surgery, which leads me to the next question. What if somebody out there watching today has already received a diagnosis of prostate cancer? They saw a physician, recommended whatever treatment it might be, surgery or radiation. How about second opinions? Should they still come to you for a second opinion? Once they've had everything done somewhere else, can you review outside records? Can you put everything together?
Absolutely. A lot of the time, whoever sees them in the prostate center is the detective. We have to put together the case and then present it to the group. That involves getting the imaging studies together, getting the pathology together, not just the reports, but the actual glass slides with the tumor biopsy on them. Our pathologist will look at them and render a second opinion on the pathology. And then once everyone's had an opportunity to review this, we get together and discuss it. And maybe there are treatment options that perhaps the prior physician hadn't thought of. Maybe the patient is beyond standard treatment and requires a clinical trial.
Yeah, I think that's important. I tell nearly all of my cancer patients to go to a comprehensive center like you're describing, the prostate center, and always get a second opinion to be comfortable with the treatment they're moving forward. So at Maimonides, the prostate center is available to patients who have been diagnosed or suspect that they may have prostate disease. And for our viewers today, and especially the men who are watching, what are some of the signs early on that they may be suffering from a problem with their prostate, particularly with prostate cancer?
So that's the thing about prostate cancer that the viewers really need to understand. There may not be any signs at all. We do a lot of pre-diagnosis counseling for men with family histories of prostate cancer. First-degree relatives diagnosed at age less than 65 who've developed prostate cancer. There are some risk groups for people who are at higher risk of getting prostate cancer, although anyone who's a man is at risk for prostate cancer. By the time some men are 70, about half of them actually have it. By the time men are 90, almost everybody has it. But because it has a very protracted natural history, not everybody necessarily requires diagnosis or treatment. So the best screening test that we have is no longer the finger test that many of our older viewers probably had.
I am sure people are happy to hear that. The finger test is no longer the best test that we have.
I'm sorry, I know you're a gastroenterologist. I'm sorry to disappoint you.
Still the best test I have.
Is not necessarily the best thing to do.
People are happy to hear this.
PSA, or the prostate-specific antigen test, which is just a blood test that your internist can draw.
Anybody can order this test. Any doctor
very
can
helpful.
order
And that's
PSA.
usually the starting point. So for patients who are at risk, family history, or Caribbean or African-American heritage, who are at very high risk for prostate cancer, a lot of those patients come without a diagnosis. Some will come with just a PSA. Say, look, my internist did this test. It's a little bit high. What should I do next? Some of them will come just for advice. My dad had prostate cancer and died at age 65, and I'm really, really worried. Or my brother had prostate cancer, and now I'm really worried. He told me I have to get checked. So that's often the way people show up. By the time symptoms show up, blood in the urine, difficulty with urination, sometimes people present with metastasis, with broken bones from prostate cancer. It's really very late-stage disease. And there's been a huge stage migration since the advent of PSA testing and screening. To lower stage disease where it's actually more curable. And this is despite the U.S. Preventive Task Force recommendation against PSA screening.
Right. A couple of years ago, all of a sudden we were shocked that they came out and said, hey, stop drawing the PSAs. And there was, at least in the medical community, a lot of outrage, a lot of disagreement with that. And patients are back now to getting their PSAs checked.
So it's very interesting that the literature looked at, there were a lot of people who studied this to see what happened after the USPTF stopped recommending PSA testing. And it turns out that there was a very slight, very short-lived dip in PSA testing, and then it rebounded back to its original levels. And I suspect a lot of this is due to patient demand. Everybody knows somebody with prostate cancer or somebody who's had prostate cancer, and everybody's worried.
Yeah, I think that's
PSA
true.
testing is happening anyway.
Is that we all know somebody who's had it. It's such a common disorder. And so for the viewers out there, what you're saying and what we know as physicians is that symptoms are rare early on in early staged prostate cancer. So men watching need to know they have to go to their internist, talk to them about prostate cancer screening, get this blood test, which is a simple stick, 1 vial, prostate specific antigen, a PSA. If the PSA comes back high, or somebody is having symptoms that are very concerning of prostate cancer and they come to you, what are the next steps? What do you normally do for a patient who comes in with a high prostate level on their blood test?
So the algorithm has changed now. In the old days, you had a finger test, you might have gotten a PSA or a blood test, and you went straight to a biopsy. Today, multiparametric prostate MRI, specifically designed to image the prostate, has been very useful in diagnosing prostate cancer and staging and in follow-up of prostate cancer. Now, this is not a black box technology. This is not like CAT scan where it kind of doesn't matter what the generation of machine you have, and it kind of doesn't matter what the protocol of the study is or who's looking at it. It pretty much gives you the same result. MRI has to be optimized for the situation that you're trying to identify. So for prostate MRI, it requires a certain magnet strength. We're no longer using endorectal coils, so everybody should be very happy about that.
So
but it does
nothing
require
is placed in the rectum anymore.
nothing inside. It's only body surface coils.
You've given our viewers 2 pieces of good news so far.
I'm
glad
sure
they're very
help.
happy to hear not so much the finger test and no longer a coil is needed.
No coil in the
placed
rectum.
inside during the exam. So the MRI, the patient just sits there or lays there.
Well, they lay there. The machine is a bit noisy and it's a little disconcerting to some people. And the study takes probably about 35 to 40 minutes to do. It's done with an injection of contrast, and it has to be run by a technologist who understands the study and read by a radiologist with experience. So we have spent about 4 years optimizing this, and our director of prostate imaging, Dr. Shaiknevsky, does an excellent job in performing these and in reading them as well.
So patients, once they're suspected, undergo this special type of an MRI, which is, again, non-invasive. There's no pain involved in an MRI aside from having an IV placed for the contrast. So after the MRI comes back, if you see something suspicious, where do we go from there?
Or even if you don't see something suspicious, that's good information as well. Depending upon the MRI result and the PSA result, your next step is a biopsy. And this, unfortunately, is the part that you can't get out of, because you don't have cancer until the pathologist looks at it on the slide and says, that's the cancer right there. The MRI informs the biopsy strategy. Years ago, we used to do straight transrectal biopsies, which meant that the probe was put in the rectum, the biopsy was done through the rectum, and that was pretty good at diagnosing most of the tumors which are on the back surface of the prostate accessible through the rectum. But there are a proportion of tumors that are not on the back part of the prostate that formerly were never identified. The MRI is very good at showing those, and now the biopsies are done, instead of through the rectum, they're done through the skin between the testicles and the rectum. The area is called the perineum. There's a small triangle there, which is very, very close to the prostate. And surprisingly, patients complain less about this. It's actually less painful to do it that way than to survive a biopsy through the rectum. And the root is very good at biopsying areas of the prostate that were formerly inaccessible. The technology has changed dramatically. Years ago, we used to use just the ultrasound to try to localize these, and today it's possible to fuse any abnormal areas of the MRI to the ultrasound in real time, so that the physician is looking at the ultrasound picture with a picture of the MRI superimposed on top of it, directing you to the exact lesion that may have been seen on the MRI for biopsy. So the diagnostic accuracy has gone up tremendously.
Very high tech.
It's actually an old technology, but it's been applied in new ways.
With the MRI.
The neurosurgeons use this for brain biopsies. The ENTs use this to navigate the sinuses. And now we're using it to navigate the prostate.
And so you get a prostate biopsy back. And we know until there's tissue, there's no issue, like you said.
Correct.
So patients must undergo the biopsy. Biopsy comes back, you get a phone call, come back to the doctor's office, there's prostate cancer. What are the treatment options available here in Brooklyn at the Maimonides Prostate Center?
So I have to tell you, I would never give somebody a diagnosis over the phone.
Of course.
And I'm sure you do the same in your practice.
Come on in, we have a long
there's
talk.
Something we have to talk about. And even a benign diagnosis is not given over the phone, because the patients then go off and say, you know what, I don't have cancer, I'm good. But they don't realize they need to be rescreened periodically if they're of an age where prostate cancer is still an issue.
We live in an age here where people are moving out of the office trying to do everything over the phone or everything on the iPhone.
Everything on the internet,
Nothing
right?
replaces the face-to-face conversation in the office.
Really true.
I tell patients all the time, my MRI, my CAT scan is normal, still come on in, because the MRI and the CAT scans look at many other areas, and there's sometimes findings that we didn't expect. So I always sit there in the office when I have to go over an MRI or a CAT scan. with the mannequin or the pictures. The phone can't replace this at all. And I know we're moving into that iPhone era of possible telemedicine, but to me, nothing replaces that face-to-face encounter.
There's no telemedicine for telling somebody that they have a potentially deadly disease.
Exactly.
There just isn't. So the patients come in and we discuss the diagnosis and the grade and the clinical stage and what it means, and if there's any additional testing to be done, we'll order it. Most of the time now, people are coming in with PSAs of less than 10. The risk of distant disease is extraordinarily low because
the risk
PSA
of distant disease meaning that it has spread
outside the prostate to other parts of the body.
So that's rare with a PSA lower
Very
than 10.
unusual now. It's not impossible, but it's unusual. And most of the discussion centers on what to do about the tumor where it started in its primary location. And for that, there are a number of options.
And so where do you go? What are the options available at Maimonides Prostate Center? I know from medical school and from even taking care of patients in our own office that there are multiple ways of going after this disease.
So the goal is not complete tumor eradication the way people think. The goal is to die from something else. And I tell patients this all the time, and at first they look very taken aback, and then they understand that it might not be necessary to kill every tumor cell to achieve that goal. So I don't care if there's 10 tumor cells inside, if you can give a treatment that has minimal side effects and stops the growth so that it doesn't spread and they die from something else, that's success.
But you're a surgeon. You want to cut. You want to, right?
So there are some
or is that
tumors,
changing?
No, that's all changing. There are some tumors that can be treated in the manner that I described. There are some tumors that will never be a problem, and the old model of care was you'd find the tumor and you would treat it 100% of the time. And it turns out that's not necessary. For people who have low grade, low volume, non-high risk prostate cancer with a low PSA, it may not be necessary to treat them, ever. So those patients are put into a deferred treatment program. This is not, the watchful waiting as in the Scandinavian studies where people were left with no treatment until they broke a bone from metastasis. This is continued follow-up with PSA periodically, exam periodically, rebiopsy at specified intervals of around 12 to 18 months. And for carefully selected patients, some of them may never require treatment.
So we're not just sending them out the door saying, hey, you don't need anything right now. They're put into a protocol of follow-up with you.
Once you have the diagnosis, you have the diagnosis forever. And irrespective of what the primary treatment has been, you're still, quote, a cancer patient. And there are patients who have trouble dealing with that, and we have plenty of support groups and psychological and other services to help with that. But to get back to what to do, so there's some patients, excuse me, who will never require treatment. And those are typically non-high grade, low volume disease, patients who have perhaps a limited life expectancy, 5, 7, less than 10 years, or even people who have just a small focus of tumor. The old days where a little tumor was like was like pregnancy. You could be a little pregnant, but you were still pregnant. A little tumor does not necessarily mean that you have a life-threatening cancer. A little tumor may mean that this is going to sit there and not be a problem. There are a lot of people who will accept that. There are some people who can't live with that, and they absolutely want treatment. So to continue with the treatment piece, there are a number of whole gland treatments, and then there's a changing treatment concept of partial gland treatment. I'll talk about both of those. So the whole gland treatment is probably all the viewers are familiar with. Surgery to remove the prostate or radiation to stop the growth or to destroy the tumor within the prostate. Surgery obviously is invasive. It's less invasive now than it used to be. When I was a resident, a fellow, you made a cut from the belly button down to the bone, spent 3 hours taking the prostate out. Guys were in the hospital for 3 days, had a catheter for 3 weeks. There's risk of problems with the urinary control, problems with the sexual function. Today, these are done laparoscopically, usually with robotic assistance. Probably about 90% of prostatectomies in this country are done that way. The hospital stay at Maimonides is less than a day. It's essentially an ambulatory procedure.
So they go in for the operation, 24 hours later, they're...
Not 24.
Less than 24.
The guy who starts in the morning goes home for dinner.
In his own house. That's incredible.
Sitting in his house, sitting at the dinner table.
Things have changed.
Things have changed dramatically. Part of it's due to advances in anesthetic technique, less use of postoperative and intraoperative narcotics. Part of it is that unless you challenge the expectations, it will always be the same. So we have really made an effort to get people out in a realistically quick fashion.
Wow.
And it's reduced a lot of the side effects and a lot of the complications and a lot of the trepidation about having surgery. Nevertheless, it's still surgery. Even if it's minimally invasive, I still have to make an incision big enough to get the prostate out through, and there is still some disability afterwards.
And you mentioned sometimes not taking the entire gland.
So I'm almost at that. So radiation is the other standard whole gland treatment, and it could be any one of several types of radiation, whether it's the external kind or the implant or a combination of both, or the high dose rate or the hypofractionated. They're all just different forms of radiation. It doesn't always kill the tumor, but it may keep it at bay long enough to achieve that goal, which is to die from something else. And radiation is very good. It's been around for a great many years. There have been many, many refinements in the way it's delivered. We no longer have problems with the bowel, problems with the sexual function markedly reduced. It's a very good treatment option. But again, it covers the entire gland, so you're treating the whole prostate, and the side effects are very similar to surgery. Problems with urinary control, problems with the sexual function. The newer treatment concept, which I alluded to earlier, is focal therapy, which is just treating the part of the prostate that's got the cancer in it and leaving the rest of the prostate intact. And when you do that, it doesn't cause as much damage to the sexual function. It doesn't cause as much difficulties with the urinary control. How good is it at treating the cancer? It's a relatively new concept, and we don't really know yet. But it's not something that can't be retreated. And it doesn't preclude somebody having whole gland therapy if that becomes necessary. Now, this concept is very similar to the way breast cancer is treated. You know, years ago, we were taking women's breasts off for breast cancer and leaving them horribly disfigured. And today, breast cancer is treated for the most part with lumpectomy and radiation or medication. And why shouldn't prostate cancer be the same way?
I think we're moving, the entirety of medicine is moving into more focal treatments. You know, we're not blasting everybody with chemotherapy that affects the whole body these days. We're using more targeted therapies, and this sounds like the next, possibly the next step in prostate care.
Well, this is truly minimally invasive because there's no incision, there's no radiation. It's the process that we've been using at Maimonides is high intensity focused ultrasound.
I was just reading this that I have to get to asking you about this. I've never heard of this before. Tell us a bit.
It's not a new technology. It's actually quite an old technology. You do biliary lithotripsy?
I'm sure we do.
It's exactly the same technology. The people who developed lithotripsy, which is an ultrasound technology, who were able to miniaturize it, package it into a transducer that both delivers the energy and monitors with a diagnostic ultrasound, and protects the venue through which the ultrasound waves go, which is usually the rectum, and really lesion just a specific part of the prostate to destroy the tumor just in that location. Now, years ago, this was applied as a whole gland therapy, and in Europe, they've been doing this as whole gland therapy for over 12 years. And the results are very similar to what you would expect from a whole gland therapy like surgery or radiation. Very good at destroying the tumor, very good at lowering the PSA down to nothing, but it has very similar side effects because you're treating the entire gland. The expectation is that focusing the ultrasound to just the area where the tumor is going to decrease the side effects. There are other modalities. There's cryoablation, which destroys tumors by freezing them to death. There is irreversible electroporation, which destroys them by disrupting cell membranes. There is interstitial laser coagulation, where you put a laser directly into it and essentially barbecue the thing. But these are technologies, some of which are not salvageable. After cryoablation, it's very hard to go ahead and remove the prostate or irradiate it if necessary. After high-intensity focused ultrasound, if it doesn't work, or if there's an area that needs to be retreated, or another area the prostate develops a subsequent cancer, that area can be treated as well. And if whole gland therapy is necessary, you can get the prostate out.
So you could always go back and do more if you need.
You could.
For the patient. So there, for the viewers out there who are watching this and might be overwhelmed by all these options that are available, it's important to see an expert like Dr. Silver at a cancer center, a prostate center, where you can have the availability to meet with the different doctors and the specialists to figure out what's the best treatment for the viewer. But still, it remains the patients have to get checked. They have to go to their primary care doctor. They have to get a PSA test when it's appropriate. What age should they start thinking about this?
That is the million-dollar question. So it's clearly true.
Tell us, Dr. Silver.
I do not have the answer to that. My professional organization, your professional organization, the AMA, many medical societies have gone through various iterations of what's the youngest age that you should test at. We know what the oldest age is. The oldest age is the point at which the patient would no longer be at risk of dying from a small localized prostate cancer if it was found. And because it takes about 10 or 15 years for a tumor to grow, that point is where the person no longer expects to live 10 years.
Which is difficult in some cases,
but
there are calculators out there that we can use to help figure. We have the same problem with colon cancer screening. the guidelines recommend stopping at some point, but we have patients who are 80 years old that run marathons, and who am I to tell them that we should stop checking them?
So my usual response to this is that if a patient comes in and he's 75, you know, and he comes in with his dad, who's 98, and wants to know what I'm going to do for the boy, that guy clearly has probably got a decent life expectancy.
He has some good DNA, right?
Yeah, the average life expectancy of a white guy in the United States is about 77, 78. But this guy who drives to Montana every year to go fly fishing with his buddies is probably not the same as the average.
Yes.
That guy's getting checked. So the opposite end of the question is how young do you need to go? Nobody really knows the answer to that. I have had patients who were screened, I don't know why, but who were screened in their 30s and had prostate cancer. And at that point, you know, there's nobody who's not going to biopsy and treat a 30-something-year-old man. But there's no recommendation to screen that early. Nevertheless, there are people who have a family history, African-American, Caribbean, they've seen their friends and their relatives get prostate cancer, and the concept is not screening. In that case, the concept is early detection. And it's never wrong to do an early detection
That's
biopsy.
exactly what I'm going to get at to conclude here for our viewers who might be saying, hey, when should I get checked? Individualized, may never be too early. Speak with your primary care doctor, which is the most important thing. And I really thank you for coming on the show. This is incredibly educational. For me, as a physician, I learned a lot, and I'm sure our viewers have a lot to digest here. But they can find you over at the Maimonides Prostate Center. And thank you, Dr. Silver. It is really a pleasure to have you on this show.
Thanks so much for having me.
Thank you for your interest in our show. Desire to become more involved and educated in your health and our community, please visit our website at www.medcastplus.com and engage with us on social media. You can also reach out to us by phone at 718-510-2103. Stay well, stay healthy, Brooklyn. Have a great day.